The next presenter is going to be Dr. Prasanna because Dr. Vanitha has opted out in the last minute because he has to go for some important function. So Prasanna will talk to us on the Trabecular MIGS. Over to you, Prasanna. Thanks for accepting in the last minute. Thank you.
Thank you, sir. Thank you for the opportunity, sir. Trabecular MIGS, and grateful to my mentor. I would not be here if not for him. Thank you, sir. And these are the 6 MIGS I'm going to talk, which are currently available in India. And my journey started in 2019 in a wet lab, where you can see these are my own pictures of me holding a stent. And this is a journey that I'm still learning as I'm going through my career. And few of the points that I'm talking is already published, and I'm just going to cover through the same. And the lenses that I'm showing in this video are TVG, Glaucos Eye Prism S6, and the Catena, no financial disclosures. So to start MIGS, it's always, the road is the direct gonioscopy, where the microscope is tilted 30 to 40 degrees towards the surgeon. And I recommend a marking in the microscope so that you are not assistant dependent here. And once the microscope is tilted to you, the eyepiece stooping can just be lifted up. As you can see here, it's a very simple procedure. I've used a lot of videos in this talk. And this is the marking that I use to help me navigate, and I'm not assistant dependent. And then the patient's head is tilted another 35-40 degrees away to break the total internal reflection. And the head is above the heart to prevent blood reflex from the Schlemm's canal. And this is the lens that I use, predominantly the Thornton style stabilization ring, where you can see a thorn-like projection which gives me good hold or good docking despite the block that I use, a subtenons or whatever that you are comfortable with. And once the docking is the most important step that you start with, and I also sometimes recommend this kind of movement that you do on either side, and you can see the block is actually here. And then this lens really helps you to navigate a much wider plane. And for a phacoemulsification surgeon or to convert into the road is actually start with the Sinski and see how consistent you are to able to touch the trabecular meshwork to see your cognitive three-dimensional orientation. And once that maneuver is mastered, you are just entering the MIGS world. So the microscopes today are very compatible. One important point is there will be an obtuse angle when you operate compared to a phaco where you will have an acute angle. So that is one point that you will notice with the MIGS. And in this surgery, if you see, the left hand seems to be non-operating, but actually the left hand is what I call the operating hand. The right hand seems to be the operating one, but it is the left hand stability that really decides how you actually do your procedure. And another video of mine here where I wanted to show the full illumination, because when you go under high magnification, the loss of light will be there, so keep it as close to high illumination as possible. And this is another published technique of mine called the overlocking movement. In the early days when I published this, you need to access superior, inferior nasal areas very easily, because the incision should be in such a plane that you will be able to move on either sides just like the overlocking movement. So these are some of the roads ahead, and this is an animation grid of the foot pedal, and it's an unedited video. So once I put the left hand gonio, I'm using my foot pedal to zoom in, zoom out, and I'm now again zooming out so that I identify the main incision, and then I take the instrument in. I'm just going back a bit, it was a bit rushed. So you can see I'm now zooming in, and now I'm fine focusing to get the trabecular meshwork. Now I'm zooming out because I want to identify the main incision, take the instrument, and then do the MIGS procedure. So this is the most important crux of MIGS, is the left hand or the non-dominant leg, which we need to orient ourselves so that we will be able to get a successful MIGS procedure. And this is again an unedited video of mine, which is 2 minutes. So once you master it, a few blood from the Schlemm's canal is a good reflex, and it comes like a C-shaped sign, unlike phaco where you just need to be that extra patient so that the blood gets cleared. Challenges which in your road ahead would be is reflection from scratch. As in this video, I'm just going back a bit, you can see a bad lens which has a lot of scratches will prevent you from seeing the surgical field very well. Excessive pressure on the cornea can actually disrupt your surgical anatomy. All these are my own surgical videos. And collapse of the Schlemm's canal, if you give more axial pressure in your left hand, you can see the Schlemm's canal actually collapsing here. And of course, managing blood inside the anterior chamber is very important. In iStent Inject W, it's very easy to manage because the bleeding will be very minimal. And this is one such Inject W cases of mine, where you can see once the stent is placed, there will be a small amount of bleed, suggesting you are in the right plane. But the challenge is for advanced mix surgeries like suture gap, when you put the nick with an MVR blade and you try to pass the suture into the trabecular meshwork, that is where the challenge comes, my dear friends, where at every juncture when you pass the suture, the bleed will sometimes, cause hindrance to the surgical plane. The more the bleed, more the blind the procedure will get. So you need to be more careful, use copious viscoelastics. Hyperviscous Helon GB Pro is something I use, and you can see it goes 360 degree and it comes the other side, called the suture gap, gonioscopy assisted transluminal trabeculotomy. So these are some important steps and tricks for the road ahead. And blood also plays another challenge, especially in this scenario. I just wanted the outside and the inside. I am thinking under eye magnification, the blood is actually inside the AC, but the blood is actually between the cornea and the lens, and I'm again doing the same mistake. So now I'm identifying the mistake, and I'm understood that the blood is between the lens and the cornea, and I'm asking the sister to put saline on the lens. And blood is not your friend in MIGS, so be it inside or outside. So now I've cleared the blood outside, and now when you do the gonio, you will get a clear view of the angle. You can see now the angles are clear. So this is a road, and these are some of the mixed procedures. Bent ab interno needle goniectomy, where we use a 26 gauge needle to do the mixed procedures. I do an inside out technique, be it bang or be it KDB. So these are some modifications in KDB which I've started last 1.5 years or so. You can see that even select angle closure cases where you can see the iris is slightly at the level of pigmented trabecular meshwork. If you are in the right plane and you open it up, it falls back. And you can also combine it with techniques like goniosynechiolysis as well. Identifying the anatomy and being in the right plane matters. Another modification is if there are frills of tissue that is remaining, you can always use an ILM peeling forceps to just, take it out like a Rexis kind of a technique. And the difference which we are coming out with the paper is KDB, the leaflets are very minimal because you do a complete scoop, whereas in bang you don't do the complete scoop, it's not made for it, and there is a chance that there can be some leaflets that can remain, which can serve as a precursor for peripheral anterior synechiae. And for want of time, I am skipping certain cases here. So this is one important case I wanted to show for the beginners. Things are looking fine, but at this moment, note, my dear friends, at some point there is a small bleed which is not what you expect. So I just stopped here and I'm assessing the area. So this area, there was a slightly posterior extension of the blade, and you can see that you need to know when to stop and what are the indications. So the plane was slightly wrong during one of my earlier stages. If you had continued, you would have ended up with a devastating complication. So as a mixed surgeon, you need to know when to start, when to stop. And there are hemigat, and even suture gap is one surgery that I have started now doing in refractory cases where this is a post-trabeculectomy surgical case, where you can see a beautiful suture gap that is being done 360 degree, and this is the failed bleb that is seen here. And there are many such collections, but owing to want of time, as well as I'm just trying to summarize my talk, IFEMA can be a common complication which is seen mostly in suture gap, but it is definitely manageable. And most of my work I have published thanks to Shibal ma'am. Some of my extensive work I have published under the guidance of ma'am, and these are some of the series that I have published. iStent Inject, Inject W. I'm not going into the difference of it, but all of my talk you can see I've extensively published it. And this is one such publication, my dear friends. I feel it is the hallmark, or going forward, this is going to be revolutionizing MIGS, understanding the angle dynamics post-surgery. There is a clear W sign in KDB, there is a remnant in bang, and there is a suture gap, bird beak configuration in figure D, that is suture gap. So this paves the way, and visualizing post-MIGS, which I published in volume 4, issue 2, I think this paves the way of whole fulcrum of MIGS, where we are able to understand how the angle is actually remodeling itself after MIGS, and Anterion is playing a lot of role in understanding this. So these are some of my data in which I have understood that this is how it works for me. Suture gap and iStent demonstrated the most significant reduction in IOP, with iStent excelling in low complication rate. But however, the number of AGM for the iStent inject patients are quite questionable. So that is why the alternative seems to be KDB. And also the other one road forward could be the combined mix, where, or the compound mix, where you mix a ciliary body procedure with the trabecular meshwork excision procedure. And again, I published that as well. And last but not least, the font of mix took me into innovations as well, where I made the first MIGS portable simulator in the metaverse, where you can practice not once but multiple times by placing the stent inside the eye, and you can get your cognitive three-dimensional skills refined. And that is another innovation in the field of MIGS. So MIGS is not alternative to filtration procedure. I want you to take this point right. It prevents the people from progressing, and mild to moderate cases are the way forward. MIGS can do for glaucoma what anti-VEGF is currently doing for retina. And these are some of my publications which have been cited by stalwarts in the WGC podium, and I'm very grateful to Tanuj Dada sir at this moment for giving me an opportunity in this wonderful AV module, and all my videos are actually now published in the module as well. Thank you Satyan sir once again for the opportunity. If I am able to do it, I feel all the neophytes can. Thank you.